Introduce. Sorry, it is my pleasure today to introduce our second Grand Round speaker. He is very well traveled. He graduated from the University of Peruna, I can't pronounce this, in Lima, Peru, and completed his postgraduate training in internal medicine at the Henry Ford Hospital in Detroit, and then nephrology and clinical research, master's in clinical science at UT Southwestern. After he served as the faculty director of the critical care nephrology at the University of Kentucky Medical Center, he joined the University of Alabama as an associate professor and the David G. Warnick Endowed Professor, and is the co-director of critical care nephrology at University of Alabama at Birmingham. He's going today to talk to us about fluid management in CRRT. So thank you so much for joining, and I look forward to hearing your talk.
Yes, thank you very much for the invitation. And It's always a pleasure to discuss this topic with critical care medicine colleagues. So this talk will be focused on what we have learned about how to do better fluid management with CRRT, what are specific parameters that we should follow, and discuss some of the recent evidence. These are my disclosures, not related to this talk. The first portion, I'm going to try to cover some concepts and metrics. And to do this, we all recognize fluid dynamics. In the early resuscitation, we try to rescue organ ischemia. We administer fluids to the patients. But also, there is a point in which we want to prevent organ edema after initial fluid resuscitation. This, of course, sometimes requires mitigating the fluid intake, at the same time, proper use of diuretics. When this is not working, we always have extracorporeal devices to remove fluid, including renal replacement therapies, CRRT, commonly used in the ICU. This gets complicated, patients that have low effective circulating volume, because we have very narrow window to optimize fluid dynamics. Put the picture of Churchill here because when we talk about fluid management, we always need to reassess the patient, right? So really, this is an area of care that makes us humble and also forces us to interact and try to create adequate treatment plans for the patients. So the recognition of fluid overload in critical care literature is well established. Of course, there are phenotypes here, and we now start recognizing this. But overall, patients with fluid overload have higher mortality when we assess epidemiologically this parameter in the ICU. This started with observations in children many years ago, where it was very consistent that children that die in the ICU had double fluid overload, and also when you model fluid overload and adjust for different other clinical parameters, the risk always fluctuated between twice or three times increased risk of mortality. In adults, this is one of the earliest studies in the population of critically ill patients with acute kidney injury. This is the CRRT study. And here, the parameter of fluid overload was evaluated 3 days prior to a nephrology consultation for these patients. And there was determined very clearly that fluid overload, just assessing those 3 days prior to the consult for AKI, was associated with increased risk of mortality. And as you can see, in the Kaplan-Meier, there is a clear separation of the lines since early on after this time zero of evaluation, and the adjusted mortality rate is about twice the risk of increased 30 and 60-day mortality. Different populations, multiple studies. This is one study from our group where here we wanted to see if this parameter of fluid accumulation, not as fluid overload only, but also as cumulative fluid balance, differentiate this dose-response relationship according to the status of the patient in terms of kidney health. That means patients had AKI or not, and patients have underlying CKD or not. So as you can see in the right side of the slide, the cumulative fluid balance in the first 72 hours of the ICU admission had a dose-response relationship with the standardized mortality ratio, independently if patients had AKI or CKD or the combination of both. And when you model this to try to identify clinical cutoffs that can guide our practice, you always get cutoffs around 10% to have an inflection point in which the relationship with mortality increases, therefore, potentially patients that may be subject to interventions. And the other interesting aspect is not only the relationship with mortality that was highlighted in many observational studies, but also the relationship with organ recovery. So in this case, in this study, when close to 200 patients that were in the ICU and required dialysis and were discharged on dialysis from the hospital, were evaluated for 1 year outcome of independence of dialysis, meaning kidney recovery. Some of the factors during the index hospitalization that were independently associated with the probability of RRT independence was fluid overload at the time of initiation of renal replacement therapy. That means that our decision to start a patient on RRT based on fluid management may have impact if we are a little bit more proactive in certain patients. Right now, of course, we have data now of clinical trials that there is no reason to initiate proactively a patient on renal replacement therapy if there is no clear indication. But in the case that there is an indication of fluid management, then perhaps that can impact organ recovery later on. So this is how we were, let's say, 10 years ago, right? So we recognize fluid accumulation as a marker and potential modulator of adverse outcomes, not only in terms of mortality, but also organ recovery. But what to do when we decide that the patient qualify for fluid removal with extracorporeal support was still not very clear with evidence. And this, in the last, I would say, 5, 8 years, this evidence have come to guide a little bit better our practice, right? So this is a study we did at the University of Kentucky where we look at specifically patients that were initiated on CRRT. All these patients had acute kidney injury and were in the ICU. And we evaluated the outcome of major adverse kidney events. That is a composite outcome, combines mortality, dependence on dialysis, and also a deterioration in the GFR from baseline of 50%. So as you can see, it's not a complete linear relationship, but there is a dose-response relationship with higher fluid overload evaluated at the time of initiation of CRRT and the probability of a patient developing MAKE. And when we model a fluid overload cutoff of 10%, this significantly incremented the risk at least 2 or 3 times of developing MAKE in the following 90 days. So similar to the prior study, this looking into a shorter outcome at 90 days, epidemiologically relevant like MAKE, you can see that there is a relationship. No, but the new evidence arises and what happened during, let's say a patient was already uh, initiated on renal replacement therapy, and we now are determining how we should manage fluid in that patient, how aggressive, what are the targets, do we have anything that can guide our decisions on how to do it, right? So the first thing we did with this study was to evaluate a subset of patients that all of them were the decision was clinically made to initiate on CRRT, and the indication, the primary indication, was fluid management. Yeah, this was defined as the prescription of CRRT included on average fluid removal that was about 0.5 liters per day on average. So these patients were clinically assessed as being fluid overloaded, requiring CRRT, and clinicians wanted to remove fluids on these patients. So what we notice is that despite we want a negative fluid balance in patients, and we already doing it mechanically with CRRT, a lot of these patients still remain in positive fluid balance, as you can see there in the red dots. And if you model this fluid balance during the time of CRRT, adjusting by multiple factors, you can see that the more positive the patient are in terms of fluid balance when you want to remove fluid, the higher the risk of mortality on those patients. Also, we noticed that some patients were achieving negative fluid balance, represented here in the tail in orange, but not necessarily close to the goal that the clinicians were prescribing. Let's say a clinician rounds this morning and say, well, I want this patient in the next 24 hours to achieve a negative fluid balance close to a liter. And then you come in the subsequent evaluation, you see patient was not achieving that negative fluid balance, was only negative 300 milliliters, let's say. So you are away from your goal of fluid management. And this was represented here for patients in orange, a good number of patients as well. And maybe you cannot see it well, but there were patients as well, very few, that they were in negative fluid balance and the goal was achieved according to the prescription, right? And those are, interestingly, the patients with the lowest mortality. Of course, the next question is, why are we not achieving our prescription of fluid removal in these patients, represented here in red and orange? And there are multiple factors, right? This was not the purpose of this study, but we know in practice that this could be ineffective delivery of the treatment. Maybe we have a problem with the catheter and the treatment is interrupted, that to the point that there are many hours the patient was off treatment. It could be also that it's a communication problem in terms of the prescription. So the nurse can execute the prescription, but perhaps there is no clear understanding of what goals and how to achieve the goals. Or it could be that the patient is not tolerating, right? Just to name a few options in broad categories. So it may be, yes, we have a goal, we have a clear understanding of how to do it, but the patient is not tolerating. So we are backing our fluid removal per hour. So, and of course, the question comes, if we assess a patient as volume overloaded and we want to remove fluids with extracorporeal support, in this case, CRRT, how we can effectively and safely remove fluid in this patient. So removing fluid, which the technical term is net ultrafiltration, it's a complex topic, right? So several years ago, this multinational survey across different practitioners around the world was conducted and identified that when you ask practitioners about net ultrafiltration rates, that are commonly prescribed in their practice are very heterogeneous. There are some practices more aggressive, some practices less aggressive. And importantly, when you ask about perceived barriers to fluid management with renal replacement therapy, the most common answer was patient intolerance, right? That we, of course, understand because there are patients in which we have difficulties removing fluids. And also, the second most common barrier was frequent interruptions in the treatment. And I can tell you that at least half of the time, the interruptions in the treatment are related to the inadequate access, right? Of course, it can be clotting and other factors, but access is very important to mitigate these interruptions, among other things, right? Under prescription, in logistical reasons of not adequate or not availability of machines or not trained staff to execute these prescriptions. In a more contemporary survey a couple of years ago, the approximately 800 participants from 96 countries were interrogated into, and this was a combination. I think this survey target a good group of nephrologists and intensivists to do some comparisons. And the question was, one of the key questions was your average net negative fluid balance when you decide to remove fluid on a patient that is critically ill with AKI in the ICU. The answers fluctuated between zero point 0.5 to 2 liters net negative fluid balance per day, which is very reasonable. I think that's also our practice at UAB. For example, on average, I would say per day, we will fluctuate between 1 and 2 liters sometimes. That being said, there are patients may benefit from more aggressive fluid removal, of course, with careful monitoring, and patients that we cannot be too aggressive, right? So, but that reflects, I think, common practice that range between zero point 0.5 and 2 liters. Then, interestingly, intensivists were more likely than nephrologists to use adjunct volume status assessment methods. And I was listening a little bit the last part of the prior talk. So especially now, bedside ultrasonography is very helpful, hemodynamic markers, non-invasive parameters, intra-abdominal pressure, some of the common answers that were provided in the survey. Nephrologists, in contrast, were more likely to deploy co-interventions aimed at improving tolerance to fluid removal. The use of osmotic agents like albumin, modulating temperature on dialysate, and sometimes also the sodium concentration when we do hemodialysis. And as you can see here, one of the questions as well was how you guide your prescription of fluid removal during RRT. The most common answer was cumulative fluid balance and weight, right? So not surprising, these are metrics we collect in the ICU, sometimes not very standardized, like weight, for example. There are centers are very good to have flow sheets with in and outs fairly accurate that can be usable for the management of these patients. And then, of course, you start going down in the list, start looking into some ultrasonographic parameters, the IVC, collapsibility and size, also some people answering CVP, left ventricular filling pressures, and so on. Less common answers, of course, more bioreactants, bioimpedance, technologies that are not well standardized in their use. And in terms of what are those co-interventions to help the patient to tolerate fluid removal, the use of osmotic agents, primarily albumin, was commonly a common response, mostly by nephrologists and some intensivists as well, and the modulation of the prescription in temperature, for example, among other interventions that we can do, more so with hemodialysis than CRRT. Okay, so in the next part of the talk, I'm gonna describe what parameters are important to follow if we have that patient already initiated on CRRT and we have clinically determined that the patient needs fluid removal. Let's say in this particular patient, we have a target of net negative 2 liters in the next 24 hours. So what we typically do and how we build the flow sheets for CRRT are we integrate the intake of the patient, right, which is dynamic, as you guys know. And we quantify every output on the patient. In this particular example, patient has a little bit of output through the NG tube. And then the fluid removal, the net ultrafiltration rate on this patient, let's say, was achieved as 2.6 liters total in that 24-hour period. So then, because we wanted the patient to be negative 2 liters, certainly we have a gap there, right? So this is what we call the fluid balance gap from the prescription of fluid removal and what exactly is happening with the fluid balance of the patient. So simple calculation, simple math, the net ultrafiltration in this patient will be the total fluid removal, that is the 2,600 mLs, divided by the kilograms of the patient. We use, and there is no robust evidence about this, but we use the weight closer to the time of RRT initiation. And when you adjust by weight, you have a ultrafiltration rate or net ultrafiltration of 32.5 mLs per kg. Why I'm telling you this? Because when you read some literature, some um, articles have adjusted this by weight only and others by weight and time, meaning hour. So you get that parameter of 1.35 mLs per kg per hour, right? So that's the net ultrafiltration that this patient has received in this day one. And why this is important? Because, and I will show you in the next slides, there is evidence now that suggests that if you are too aggressive with your net ultrafiltration, you can also compromise the patients, particularly for organ recovery. And this is something, of course, that makes sense, but you need to keep in mind that that data comes from studies that have not selected the populations for only patients in which fluid removal is the main indication for CRRT. So it's taking a whole CRRT population. Yes, there is a signal that if you do it too fast, probably it also could be detrimental for the patient. So the checkpoint of safety, if you want to incorporate in your practice, it's to not to exceed the 2 ml kg per hour, unless, of course, you have a very clear indication and you will monitor that patient closely. And then the other parameter I want you guys to try to incorporate in your practice is the fluid balance gap. So that means in this case, we wanted the patient to be negative 2 liters. We didn't achieve that. The patient was only 1 liter negative at the end of that day. So we're 50% away from our goal, right? So, and why this is important? Because this parameter of the gap in your prescription and what's happening with the patient in terms of fluid balance also has an important relationship with mortality. And let's review where is this data coming from. So one of the first studies evaluating net ultrafiltration intensity and mortality in critically ill patients with fluid overload was done in about 1,000 patients from the University of Pittsburgh. They selected this population only on patients with fluid overload 5% or more at the time of RRT initiation. Okay, and they evaluated net ultrafiltration for and the relationship with the outcome of 1 year mortality. They adjusted the net ultrafiltration intensity based on the kilograms of the patient and also the total number of days of the treatment. So this is a metric that's why I've told you that you need to take into consideration the units when you want to extrapolate these. But the study interestingly showed that if a patient has indications of fluid removal, let's say in this case, select with a fluid overload more equal 5% at RRT initiation, and the patient tolerate more fluid removal, more than 25 mLs kg per day versus less equal 20, there is an improvement in mortality, right? So not surprising, because if the patient has fluid overload and we can remove more fluid, we are not surprised these patients did better when evaluated with the 1 year mortality outcome. Now, the other study, also led by Raghi Murugan from Pittsburgh, used data from the renal trial. The renal trial was a trial done in the early 2000s about the dose of CRRT in patients with AKI in the ICU. So this data, of course, collected net ultrafiltration rate data, which was used for this post-hoc analysis, including 1,400 patients. So here, the net ultrafiltration rate was adjusted per hour and by the weight of the patient. So the units, the numbers will look different, but it's because it was adjusted by hour. And the outcome was 90-day mortality. So what they found is that net ultrafiltration rates greater than 1.75 ml kg per hour, the highest tertile in this cohort, versus less than 1.01, that was the lowest tertile, were associated with lower survival. Okay, so remember, in this trial, patients they had multiple indications for renal replacement therapy. Could be solute control, hyperkalemia, acid-base disturbances. not only or exclusively fluid management. So when you take a whole epidemiological population of patients on CRRT, yes, you can see this signal that is very relevant, that's showing that if you remove fluids too fast, you can also have a detrimental effect on patients. And of course, because this is observational studies, a lot of the critiques in the subsequent months, years was, well, there is indication bias, clearly for what I said, that patients may have different indications, not necessarily fluid management for initiation of CRRT in that trial. So the investigators try with different cohorts to evaluate if this relationship of higher net ultrafiltration and increased mortality could have mediators like fluid balance of the patient, the hemodynamic status, and some key electrolyte parameters doing some mediation analysis. And they found that no, in this still observational data, still partially addressing indication bias, it seems that this signal is real, that net ultrafiltration above 1.75 was independently associated with increased mortality. In a subsequent study, when they look not only the mortality outcome, but they look also the kidney recovery outcome at 90 days, in this trial, they found that, not surprisingly, patients that had higher net ultrafiltration rates above this threshold of 175 had lower chances of kidney recovery, meaning dialysis independence at 90 days, right? And this makes sense as well, because if we have a patient that is recovering, surviving, and we really push very aggressive fluid removal, then we certainly can compromise organ regeneration, in this case, particularly the kidney, right? The tubular cells need to regenerate. So with this data, I think the prudent comment and or summary to the community, to the scientific community, is to recognize that when we have in the x-axis fluid removal, ultrafiltration rates, net ultrafiltration rates, there is now observational evidence that there may be a U-shaped relationship with mortality, meaning that patients that really need fluid removal, if we don't do it effectively, they may have higher risk of mortality. And patients in which either they need fluid removal or is not the main indication, if we go too fast, we can also create problems in the patient, particularly both one related to organ edema and the other one could be related to organ ischemia. So this is something to keep in mind, that there is perhaps now a safety parameter in our fluid removal with CRRT, that is the ultrafiltration rate, the net ultrafiltration rate. And this, I said two earlier because we use that in our practice. The 175 was developed here because this was the highest tertile in this particular subset of patients. But I think a more operationalizable target is a 2 ml/kg per hour. That is what we use in our practice to basically tell the trainees, if you prescribe higher than this, you need to have a clear indication, right? So because there is evidence that say that perhaps we should not push too fast. And the explanations, of course, the compromising perfusion to the organs can really affect outcomes in the patient. And this could be at multiple organ level. And I just show you the data on the kidney recovery that was very convincing in this relationship. Now, couple of additional comments. When we talk about net ultrafiltration, it doesn't incorporate the fluid balance of the patient, right? So one thing is the fluid balance of the patient and the fluid balance goal that you may have for that patient, as we said in the example previously, -2 liters in the next 24 hours. And the other thing is how much fluid is removed with the machine, because that net ultrafiltration is adjusted according to the intake of the patient to achieve the goal. So you can have in the same patient the same net ultrafiltration rate in two different dates, but with different fluid balance. And in one day on the left, the patient is below target because clearly that patient is still in positive fluid balance, versus in the second day, perhaps because we mitigate the intake, with the same net ultrafiltration, we are on target with fluid balance. That I put this example because this is a dynamic flow, right? So when we talk about net ultrafiltration rate, we should couple this with the fluid balance of the patient and the fluid balance goal that we have with the prescription. For that reason, we were very heavy proponents of minding the gap on your prescription based on the data on the study I showed you before for two reasons. A lot of the time, we are below our target on the prescription of fluid removal. So this is data on 800 patients in which the average fluid removal was half a liter per day during the period of CRRT. You can see that the prescribed fluid balance goal, so what we wanted, it's represented here in red to the left, negative fluid balance. But a lot of patients still were in positive fluid balance or under the goal of negative fluid balance. So if I know you guys have a lot of data capability there at Mount Sinai, and I would love to see a figure from your practice in terms of what you prescribe and what you achieve, and what is your gap, and then that could be a quality indicator that you can use to improve your fluid management with CRRT, right? As we certainly use in Kentucky at that time, and I can tell you the data from UAB is fairly similar. So the other important aspect is that despite net ultrafiltration rate on the right doesn't phenotype patients necessarily if we don't couple it with fluid balance, if we determine phenotypes based on what we achieve in relation to our prescription, we can identify clearly a patients with higher risk. Now, the cause of the higher risk needs to be individualized or identified specifically for a patient. But I will tell you that those patients in which you want to remove fluid and you are not able to achieve that goal, those are patients with high risk of mortality. It could be because they are too sick, or it could be because we still have a chance to do something better with CRRT to mitigate the risk of that patients in terms of mortality and organ function. Now, when we look into patients and we want to remove fluids, yes, similar to the first study I showed you from University of Pittsburgh, higher tolerance to net ultrafiltration rate, lower the risk of mortality. That's in the lower side of the slide, right? So we want to remove fluid, patient achieve that target, then patients have higher chances of survival. Now, on the top of the slide, it's the relationship between the gap and the mortality rates with this discrepancy between the fluid balance that the patient achieves and the fluid balance that you are prescribing with your CRRT. And you can see that the higher the gap, the higher the adjusted odds of mortality, right? Of course, we need to be careful with these studies. These are observational studies subject to residual confounding, but there is a signal. There is a signal into a metric that can help you stratify your patients of higher risk, because in not all of them you may be able of fluids, but in some of them, you can improve the processes to be more close to your prescription in terms of fluid management. And the question, of course, what causes the gap and how we can close the gap. And this is a quality improvement work in progress, right? So keep in mind, in a broad level, inadequate prescription. So perhaps the prescription is not communicated or entered correctly into the electronic health record. There is ineffective delivery. It could be because the circuit is not optimally working. We have interruptions. I mentioned catheter as one of the common interruption problems, or patient intolerance, right? Among others. So just keep in mind this frame of potential options to evaluate when you identify this gap in your practice. So what we recommend with the literature that I presented today. So at this stage, we promote an individualized approach of fluid management with CRRT. because patients may have different fluid balance status, different tolerance to fluid balance status, and also your goals of fluid removal may be different for a patient that it's clearly in acute heart failure exacerbation versus a patient that is in early hours of septic shock. And also the impact of fluid derangements may vary between patients. So for any intervention, when the evidence is not robust to create a standardization in terms of protocols, this is how you start, this is how you adjust, then we need to draw this U-shaped curve of a harm benefit for whatever intervention we have. In this case, recognizing that high net ultrafiltration for one patient may be low for a different patient and vice versa. Therefore, an individualized approach is what we should do. That being said, you can have an individualized approach to determine your fluid balance goal with your prescription. But you need to have a way in your processes to monitor that prescription and the goals of the prescription to see if adjustments are necessary. And this is the part where we struggle with CRRT programs in the US in general or around the world, that we don't have enough clinical decision support tools to help us recognize right now of my 30 patients on CRRT in the ICU, there are three that I'm very offset with the goal. And either I need to change the goal because that patient don't need fluid removal, or the patient is not tolerating fluid removal, or I need to do something to get closer to my goal, right? So these are tools we're trying to develop, are very, because require real-time data, are not that simple to have, but this is how we are trying to improve the practice in the future to be able to identify those high-risk patients and tailor interventions on them. Certainly encouraging the use of bedside ultrasonography. I know intensivists are very skilled in using these tools, and these tools, as you use for assessment of fluid responsiveness or fluid needs, you can also use them for assessment of tolerance to fluid removal, and also to identify in which patients we should do it a little bit more intensively. And I will put you an example of how the practice of CRRT was improved with evidence that perhaps there is a target on an average dose, right? So, as you know, the standard dose of CRRT that we prescribe is typically 25-30 mLs per kg per hour of total effluent. This evidence comes from two clinical trials, the ATN trial and the renal trial that we discussed post-hoc analysis earlier, comparing a dose between 20-25 and doses 35-40, showing that higher doses on average throughout the period of CRRT did not have any impact on mortality, AKI duration of kidney recovery. Therefore, the practice was adopted to have an average dose of 25-30 mLs kg per hour. However, we all recognize in practice now that if we have a very hypercatabolic patient with very clear solute control goals, we can prescribe higher than this. We can go 35, 40, or even 45. If we have cases sometimes of hyperammonemia that we need to really aggressively beat the production, sometimes we will prescribe higher doses, right? But if a patient achieves goals of treatment and we want to maintain a support with CRRT, there is no reason to prescribe a higher dose, because this is non-selective clearance that is going to remove also nutrients and antibiotics and things that are beneficial for the patient. So the same practice we can incorporate into fluid management, right? So the first time 20 years ago, when the gap between what you prescribe in terms of dose and what you actually deliver on the patient was evaluated, there was a gap of 32%. I can tell you what we prescribe in fluid management and what we achieve on average on all the patients, it's a gap much more than 32%. And I can guarantee you that happens in every practice because we don't have enough tools to monitor the patients and to intervene timely, right? But these days, like 20 years later, when we monitor this metric of the discrepancy in your prescribed a dose of CRRT and what you deliver, very consistently below 10%, right? So this is now a quality indicator of CRRT delivery that programs track, and you can see it's important because it's cost effective. You don't want to waste dose if the patient is not delivered, is not receiving that dose, and this is an important improvement in the last 20 years. Just understanding based on evidence what will be a target dose and how we can track that gap. So, of course, from the prescribed dose to the delivered dose, if we extrapolate, treatment interruptions can affect what we prescribe and what we deliver. Some of these interactions are unintended, and some of them are intended if we need to send the patient for a procedure, for example. And also, there are some biological aspects in the filter that the filter will lose efficiency. But that's a different story that we cannot control. It's very heterogeneous according to patients and their status of hypercatabolism. Same thing we can extrapolate to fluid management. We have a prescribed ultrafiltration net ultrafiltration fluid balance goal, and we need to be conscious about the treatment interruptions intended and unintended that preclude our delivered ultrafiltration net and therefore our target fluid balance goal. And of course, we need to consider patient factors, the cardiac and hemodynamic stability of the patient, the vascular refilling capacity. Sometimes in the more complex cases, that vascular refilling capacity is what we are sometimes impatient to wait for, and sometimes we are hesitant also to keep a little bit of that dose of vasoconstrictors that can help that interstitial refilling capacity to the vascular space. And the trajectory of these patients for both critical illness, AKI, and fluid balance needs to be tracked in a way that we can identify patients in which we really are having challenges to optimize our deliverables. So dashboards is one of the solutions. There are centers already. This is an example from Cincinnati Children's, generating dashboards to identify, as you can see in the bottom right, patients that they track how they achieve their fluid management goal. And this, if you create these resources close to real time, you can even have processes to intervene in patients that really are off target in terms of goals of treatment. So with that, I'm going to finish and give the opportunity for questions. I will say that fluid removal during CRRT is a potentially modifiable risk factor that needs to be tested in interventional studies. Some of these studies are ongoing in pilot phases, targeting different strategies, intensive, less intensive, of net ultrafiltration rate. Observational studies examining these parameters, net ultrafiltration rate and outcomes, may be confounded by indication. Keep in mind, this data I presented today is observational only. The goal of fluid removal may be affected by inadequate prescription, so we need to work with clinicians, deliverables with nurses, and also our processes of CRRT delivery, and also tolerance to the patient. And this is also an area we can develop evidence to identify tolerance to fluid removal with non-invasive tools that now are available in the ICU. And just keep in mind that the percentage gap from your prescribed fluid balance goal should be continuously monitored. And I particularly propose this as a new quality indicator of CRRT delivery. With that, I'm going to stop. Thank you for your attention and happy to entertain questions, comments. Thank you.
Javier, thank you for joining us. Thank you for your talk. I do have a question. When you're setting your targets, when you're analyzing KG, are you using actual, or are you using their pre-morbid? Are you using ideal body weight? Which weight are you using to set your targets?
Yeah, that's a great question. As I said, there is no strong evidence what's the best way to use, but the way that we have done in these studies I presented was the weight closer to CRRT initiation. Now, when we dose CRRT, we recommend to use the exactly the same weight, the weight closer to your decision of CRRT initiation to determine your dose, and you can use that also to track your net ultrafiltration rate. But this is changing too, right? Because what are we observing now? We observe two phenotypes of patients. So when I show you the data of the renal trial, the ATN trial, you need to recognize that data is 15 years old. How much our practice has changed. In the past, the median time on CRRT for patients was 3 to 4 days because a lot of these patients die. Now, the mortality on patients on CRRT has been decreasing from 80%, now is down to 50% in developed countries where that they have adequate resources. So we are now observing two phenotypes of patients, patients that have a median duration of CRRT of 4 or 5 days, and patients that stay on CRRT longer, that even exceed the 10, 14-day mark. So yes, when we give this recommendation about weight closer to your RRT start, is looking into evidence when our practice was weighted only on the first week of treatment. But now we have phenotypes of patients that perhaps readjusting the weight is very appropriate when they have a prolonged exposure to CRRT. So in my personal practice, if I have a patient already past 7 days, when I know I will see other type of complications with nutrition, with depletion of electrolytes like phosphate, for example, I readjust the dose according to the most current weight of the patient. So what you call it, the actual weight.
Thank you so much for the amazing talk. I don't know if Amanda or anyone else in the audience has any questions. We have a few more minutes to open up to the group. Sounds like you answered everyone's questions with that amazing talk. Thank you so much for your time. We really appreciate it.
Thank
And
you
then,
very much, guys.
thank you. Bye, everyone.